Guys, let's start with so we finished off the sensory, now we want to cover motor. So we said sensory had three or more, right? First, second, third order neurons, and then motor had two, upper motor neuron and lower motor neuron. So we're going to go over the pathway for this, and then we're also going to go over the different, what they call lesion signs when you damage either of the pathways. So if I go descending, right, from the brain down to the spine, that is motor sensation, right? So this is all MEV. So from the cortical spinal tract, I start in, so let's just call this cortical spinal tract. Where's the cortex? The cerebral cortex is basically inside of the brain, right? So we call this cortical spinal tract. We'll define that a little bit. So it starts off in the cortex and it travels through what we call an upper motor neuron. And this upper motor neuron crosses in the medulla and then it travels. Now that's not enough room, so let's push this over a little bit to the left. So I have the cortex and I have what we call an upper motor neuron, crosses in the medulla, and then it ends on what we call a spinal nerve. But in this case, we're going to give it a specific name. This is because this is traveling through pyramids. So this is an upper motor neuron that travels through pyramids. It's called pyramidal. Okay, this guy here is called a lower motor neuron. It's basically a spinal nerve, right? Spinal nerve, or if it's going to the face, it might be one of the cranial nerves. But we call it an alpha motor neuron or a lower motor neuron. And they synapse or connect to and control your muscles. So they are your final connection to the muscle. So we did this, right? We said really quickly before, we said this was a nerve, it controls, and this was a muscle, it moves. Together, they're a motor unit. What if I break the nerve? Then I guess the muscle can't move, right? So we're going to go over different signs that you might see if you damage a lower motor neuron, like a spinal nerve, or if you have a stroke and you damage one of the pathways for the upper motor neuron, right? So this one's pretty easy. And then this is pyramidal. It's a pathway that I can control. It's from the cortex to the spine and it's a track. So this thing right here is just cortical, right, from the cortex, spinal, right, S, and then tract is a pathway that takes this type of information down to the muscles. So cortical spinal tract is CST. It is control. It's something I can think about. I can do this and I can think, okay, I need to close my hand, I need to open my hand. It's something I control. Passes through pyramids, or it's called pyramidal. There's other pathways that are outside the pyramids, and we're going to call them extra. So we call it extrapyramidal. And if it's not control, it must be some type of reflex. So these are examples of fairly reflexive pathways. But for the purpose of class, we're going to categorize them as reflex. And we're going to keep this guy as control. So if I don't have control, then it must be something that's reflexive. So these pathways, I can make up a whole bunch. If it is not cortical spinal, and it's not, another one that we have is called cortical bulbar, we'll talk about later. If it's not cortical spinal, it's extra. If it's not cortical spinal, it's extra. If it's extrapyramidal, it's a reflex. If it's outside the pyramid, it's a reflex, right? And so what are the examples that we have? I can name anything. If I had a red nucleus, I could call it rubrospinal, starting from the red nucleus. If I had a substantia nigra, right, I could call it nigro spinal pathway. Or if I said another one, reticulospinal or tectospinal or 90-90 spinal, any kind of spinal, blah, 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 spinal. If it's not cortical spinal, then it's extra, right? And if it's extra, it's a reflex. So let's talk about, I'm just going to write a couple of examples. These are not the only ones. Reticulo. What else did I have? Rubro, tecto, nigro, and anything else you can think of, but we're going to limit to that. So we have extrapyramidal, which is reflex. So let's do the easiest one, because we already talked about if I damage a nerve to a muscle, what am I going to have? So let's kind of go back and forth between the lesions. We'll start off with one simple, and then we'll divvy them up between the two. This, if I damage over here, then I would have what we call a lower motor neuron lesion sign. What are the signs? Well, are my muscles going to be dying? So there's one that I'm not going to write on here, but you guys should know if you're going into medicine. It's called muscle fasciculations. That's a sign that the muscle's starting to twitch. That means it might be dying. Um, but don't make an assumption that, oh my god, my eyeball, like the muscle above my eyeball is twitching, it's dying. No, 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 no. This is like when you have damage. So muscle fasciculations is one. We're not going to test you on that one, so I'm not writing it down. But would I have hyperreflexia, areflexia, or hyporeflexia? Well, I'm not going to have hyper because a reflex means that I have to have control of the muscle, right? But if I break the pathway to the muscle, I'm probably not going to have a reflex. So it can be areflexia. And what does that mean? A is without reflex, right? Without a reflex. Or if it's damaged but not quite completely cut off, you could have something called hyporeflexia. Okay, so that's pretty simple, right? And let's go back to this one. If I damage, so this is not all three, we're going to go over three, but I want to take you back to damaging an upper motor neuron. If I damage an upper motor neuron and I leave the lower motor neuron intact, upper motor neuron, right? Then what are some signs that I'm going to have? Well, I can base it on the fact that I have a pathway. If I can't control it, then are my reflexes going to be more pronounced, less pronounced, or normal? Well, if I have no control, so when you're sitting in a doctor's office and they have something coming at your knee, right, to test your reflexes, if you see it coming, you tense up. So that's your ability to actually soften or repress your reflexes. But if you have no control over your reflexes, then they're going to be more pronounced than usual. So hyperreflexia is a sign that maybe you have no control over it. Okay, let's go back and forth. Well, what kind of paralysis or paresis, partial paralysis, would you have? Well, if I'm more reflexive, would I be spastic or flaccid? Well, I'd be spastic. So we say you might see signs that somebody has spastic paresis. Paresis is partial paralysis. So we're going to call it paresis. It's not paralysis. Paralysis is the inability to move, right? And what about this? If that's spastic, this must be flaccid, right? Because I really can't connect to the muscle. So we call this spastic paralysis. Depends on the degree of paralysis going on, right? So spastic paresis, flaccid paralysis. And let's make one more comparison. So when we talk about the foot, when you swipe the underside of a baby's foot, right, with a metal object or with an object, they will actually curl their toes backward and push toward the object. Okay, that's normal in a baby. So a baby in skis is fine, right? A baby in skis. So we call it Babinski. But is that normal in an adult? When somebody tickles the underside of your foot, do you pull away from the thing that's tickling you? Yes, you do. So your toes curl toward the object and it pulls your foot away. But what happens if you see a patient that pushes that way? That's called Babinski sign. So Babinski is normal in a baby because a baby in skis, right? But it's not normal in an adult, and it's usually a sign of an upper motor neuron lesion. Maybe they had a stroke, maybe they hit their head. For whatever reason it is, there's a lesion in the upper motor neuron, and one of the signs is Babinski. Babinski, Babinski. But if I can't do a reflex, can I ever have a Babinski in somebody that has a lower motor neuron lesion? No. So this one, you're not going to have Babinski. So we say no Babinski, no Babinski. So you got it? Here we go. Concept all over again. So I have motor pathway, right? I have sensory pathway. It's 3 or more neurons in a row. Motor pathway has 2 neurons, and there's upper and lower motor neurons. The primary one that we're going to look at, but we're going to do one for the face, but just imagine this. This is what I'm going to test you on a lot. So cortical spinal tract is the motor pathway that goes from the brain, the cortex of the brain, travels all the way down to the spine and connects onto the lower motor neuron, which then travels to a muscle to control it. If I damage the lower motor neuron, then I'm going to have signs of no reflexes, right, areflexia, or diminished reflexes. Hype, this is, I forgot the O between the hype. It's just hype. Hyporeflexia. Flaccid paralysis because I'm not going to be able to control the muscle, right? It's going to be flaccid. And no Babinski because there's no reflexes. But what about for upper motor neuron? Well, upper motor neuron, because the lower motor neuron is intact, right? If I damage the ability to control, then my reflexes are going to be more pronounced. And what are the reflex pathways? Reticulospinal, rubrospinal, tectospinal, nigrospinal, 99 spinal, blah, 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 spinal, right? So they're extra. Extra is reflexive. So if I have an upper motor neuron lesion sign, I damage this pathway, I'm going to have more reflexes, right? So I'm going to be hyperreflexia. I'm going to be more spastic. I'm not going to be able to control and smooth out my responses to stuff. So it's going to be spastic paresis. And then I'm going to have Babinski sign where I sweep the underside of the foot and I'm going to have this kind of pronounced look. Instead of curling away, I'm curling the toes down. Toes are going to curl upward and you're going to push towards the injury. Woohoo! You guys doing good. So what are the two? Upper motor neuron, lower motor neuron. These are two for the motor pathway. And let's go over corticospinal, right? We said corticospinal was that. Yay, you guys got this down. So easy for you. So here we go. Cortical spinal is to the body and the skeletal muscles. But cortical bulbar, here's where I'm going to show you. Cortical spinal for the body. Cortical bulbar to the bulb. And here's how you remember bulb. Draw a light bulb. And make him smile. Okay, so cortical bulbar tract, or CBT, goes to the face, and it's the motor to the face. So it's going to have the same type of pathway, but it's to the face. So there's an upper and a lower motor neuron, and they're to the face. So there's certain muscles and certain cranial nerves that control it. For your level, don't worry about it. For med school, yes, you're going to have to know the nerves of the cranium, or the cranial nerves that control the motor components to the face. Yes. Okay, cool. So cortical spinal passes through the pyramids, right? Anything outside of the pyramids is extra, and it's reflexive in nature. Cortical bulbar to the face, cortical spinal to the body. So cortical bulbar to the face, cortical spinal to the body, and it goes through the pyramids. If it's not through the pyramids, then it's extra, and it's considered reflexes. Good. So here we go. Same pathway all over again. Don't worry about dividing into medial and lateral. You just want to understand. So remember I said there was vestibulospinal, right? There's tectospinal. So all of these are considered extra because they're outside of the pyramids. Reticulospinal, extra. So these are reflexive in nature. Rubrospinal, extra, right? So cortical bulbar to the face, cortical spinal to the body. Vestibulospinal, tectospinal, reticulospinal, rubrospinal, spinal, any other spinal is all extra pyramidal, and a lot of times they're associated with reflexes, like your ability to hear and see or respond to a sound by moving your eyes, or even balancing through coordination. Basal nuclei. Remember, what's the function of basal nuclei? It's to initiate movement. We're keeping it as simple as initiate movement. Cerebellum, right? Little brain. So you said proprioception, right? Balance, coordination. And let's get to the questions right here. What are the main ascending pathways or sensory? There's more than this, but the two that I want you guys to know are STALS. And you guys know that STLS was Patsy, pain, temperature, crude touch. DCML, or posterior column, as it's known. DCML is poor viridum siligae, right? So proprioception, vibration, two-point discrimination, stereognosis and graphesthesia, spinocerebellar tracts, right? In general, you know it was balance, coordination, and unconscious proprioception. The two proprioceptors that I constantly harp on you guys with are the muscle spindle fibers for detecting stretch in a muscle, and Golgi tendon organ, which detects tension in a tendon. And then there's a third one, but I'm not going to test you guys on that. That one's in the joint capsule. What are the main descending pathways for motor? There was cortical spinal, and then we didn't write this down, but there's cortical bulbar, right? Cortical spinal to the body, cortical bulbar to the face, and it passes through the pyramids, whereas rubrospinal, vestibulospinal, reticulospinal, tectospinal, blah, 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 they're all considered extra, so they're part of your reflexive pathways. And then what is ALS? This was a question in your study guide. What is ALS? Well, it's also known as Lou Gehrig's disease, and I pulled this off from the ALS Association site, and here's the address if you guys want to look at it. So amyotrophic lateral sclerosis progressive disease that affects nerve cells, right? And then this one basically refers to, so we said nerve, muscle. If I degenerate the nerve, I have atrophy in the muscle. That's all that it's referring to. Well, that's not all that it's referring to, but that's the meaning of the word itself. So degenerates leads to scarring, hardening, sclerosis in the region. Okay, done.